Hello everyone. I am myself Dr. Rajesh Gubba. I am the general medicine educator. In this session, I will be discussing a very important topic in the neurology, that is the Huntington's chorea. So first, I will just give you a clinical case presentation of how the case presents. So this is the patient, right? 40-year-old man brought to the doctor by his family for rapid intellectual decline. Okay, that is the chief presentation. Examination shows fast semi-purposive movements in the hands. His father and grandfather had a similar illness. What is the diagnosis in this patient? Presenile dementia, Lewy body dementia, corticobasilar degeneration, Huntington's chorea. Right? So as we are discussing the topic of Huntington's chorea, definitely the answer will be the Huntington's chorea. Right, so this Huntington's chorea, the very important presentation will be the semi-purposive movements. Right, the fast semi-purposive movements are the classical description in case of the chorea. And let me discuss in detail about this topic of the chorea. Before that, you take this presenile dementia. Presenile dementia, it is seen in patients with it is seen in patients with Down syndrome. Okay, presenile dementia, it is seen in Down syndrome. Whereas you take this Lewy body dementia, what will be the presentation of these patients with the Lewy body dementia? That includes the hallucinations, right? And the other important feature will be delusions and as well as dementia. Right, so these will be the features of the Lewy body dementia. Next, followed by that, you take the corticobasilar degeneration or corticobasal ganglionic degeneration. So in these individuals with corticobasal ganglionic degeneration, the manifestation is by asymmetric dystonia, right? It is in the form of asymmetric dystonia, and these individuals will have what is called apraxia, that is loss of visuospatial skills, and the focal limb myoclonus, right? So there will be myoclonic movements or involuntary movements within the limbs. So this is what is the presentation in case of the corticobasilar degeneration. Now our topic of the discussion is the Huntington's chorea. Now, first of all, you need to know what is the chromosomal defect in case of the Huntington's chorea. So please remember this mnemonic hunt. Right? So if you take this word hunt, it has 4 letters H-U-N-T. So the defect, it is present on the chromosome number 4. Right? The defect is present on chromosome number 4. And what type of inheritance is seen in case of the Huntington's chorea? It is autosomal dominant type of inheritance. Right? The type of inheritance is autosomal dominant type of inheritance. And these individuals, they have the property of anticipation. Right? Now what do you understand by this word anticipation? That is increase in severity of the disease in successive generation. Right? So increase in severity of the disease in successive generation. Right? So that is what is called as the anticipation. Now, and at the same time, you need to know what is the gene mutated in case of the Huntington's chorea. The gene mutated in Huntington's chorea will be, or the type of mutation, if you see, it is a trinucleotide repeat. Right? It is the trinucleotide repeat of the codons CAG. And how many repeats will be there? More than 40 repeats will be there. And what is the name of the gene which is being mutated? It is Huntington gene. Right, the gene which is being mutated is the Huntington gene. Now, and at the same time, you need to know what is the abnormal protein which is accumulated in the neurons because of this mutation. So, the gene which is being mutated is the Huntington gene which is being mutated, and because of the Huntington gene which being mutated, an abnormal protein will be formed. And what is the name of the abnormal protein? The name of that abnormal protein will be ubiquitin. Right, the name of the abnormal protein will be ubiquitin, and this particular ubiquitin, it gets accumulated in the neurons. Right, this will get accumulated in the neurons. Okay, and this abnormal protein, it gets accumulated within the neuron, causing neuronal firing. Right, causing neuronal firing. And because of this particular neuronal firing, the individual will have chorea, right? Involuntary movement, that is called chorea. So this is the basic introduction of the Huntington's, right? The chromosome which is being defective is the chromosome number 4. Type of inheritance is autosomal dominant type of inheritance. And in successive generations, the severity of the disease increases. And the gene which is being mutated is a Huntington gene. And the type of mutation will be trinucleotide repeat of CAG codons of more than 40 repeats, and because of this mutation you have an abnormal protein which is being formed, that is called ubiquitin, and that gets accumulated in the neurons. So because of this abnormal protein getting accumulated in the neurons, that will cause neuronal firing, causing the chorea. Right, now after having discussed about this basic introduction, you need to know the clinical features of the Huntington's chorea. So the clinical features in case of the Huntington's chorea are usually seen around 4th to 5th decade. Right, they are usually seen around 4th to 5th decade. And what will be the earliest manifestation? The earliest manifestation, as the name itself suggests, that will be chorea. That will be the earliest manifestation. Right, and why is this particular chorea? That is due to damage to caudate nucleus. Right, that is due to damage to caudate nucleus. Right, and as already I have discussed, like what will be the in what way the involuntary movements will be there in these patients with the chorea. So there will be semi-purposive fast involuntary movements. Right, there will be semi-purposive fast involuntary movements. Okay, so that is what you wear within the upper limbs or within the hands. Right, so that is the description of the involuntary movements in case of the chorea. And in these individuals, they will also have the slowness of movements, right, as the severity of the disease increases. So what did I tell you? In the successive generation, the severity of the manifestations will increase. So they will also have bradykinesia as well. Right, that means they will have these involuntary movements, but in a slower manner in the successive generation, but initially they'll have fast involuntary movements within the hands. Okay, and in these individuals, they also have the features of the atypical Parkinsonism. Now the question is, what is the feature of atypical Parkinsonism in Huntington's chorea? Whenever the neuronal death occurs, that will result in dementia. So because of the accumulation of this particular abnormal protein, right? What is that abnormal protein accumulated? Ubiquitin. So because of the ubiquitin accumulation within the neurons, there will be the neuronal death, right? So there will be neuronal death, right? And because of this particular neuronal death, the individual will develop dementia. And please remember, this particular dementia, it is a feature of atypical Parkinsonism. right? It is a feature of atypical Parkinsonism, right? So that is about the feature of atypical Parkinsonism present in the Huntington's chorea. Now these patients with the Huntington's chorea, they also have rigidity, that is, they will develop stiffness in the muscles. Right, they develop stiffness in the muscles, and that particular stiffness, which is nothing but your rigidity, that will be in the form of cogwheel rigidity for upper limbs, right? Cogwheel rigidity will be present in the upper limbs, whereas in the lower limbs you have the presence of the lead pipe rigidity. So lead pipe rigidity, it is present in the lower limbs. Okay, so this will be the form of the stiffness in the muscles. This will be the form of rigidity in case of the Huntington's chorea. Cogwheel rigidity for upper limbs, lead pipe rigidity for the lower limbs. Now how will you investigate these patients with the Huntington's chorea? The investigation of choice will be the MRI, right? And that means the first line investigation, right? But definitely investigation of choice will be what? That will be the genetic analysis, or right, genetic analysis. So if you take the MRI of these individuals, the ventricles, they are enlarged in the form of a box, and that we call it as the boxcar ventricles, right? You can see that ventricles, right, they are in the form of a box shape, and that we call it as the boxcar ventricles. These are the characteristic features in the MRI of patients with the Huntington's chorea. So coming on to the treatment of these patients with the Huntington's chorea, let me tell you, there is no cure for Huntington's chorea. And not only cure, even the progression cannot be halted in this patient. Only the treatment, if at all, if you want to give, it is just purely symptomatic treatment, right? It is purely symptomatic treatment. Now, what will be the drug of choice in patients with the Huntington's chorea? These patients with the Huntington's chorea, they have excess amount of dopamine. So you need to give dopamine depleters, and that particular dopamine depleter will be tetrabenazine. Right, tetrabenazine is been given. And what about levodopa? Levodopa, it is contraindicated in patients with, right, it is contraindicated in patients with the Huntington's chorea. Why? Because dopamine is in excess quantity in patients with the Huntington's disease. So levodopa is contraindicated in this patient, right? Next, and at the same time, you need to know what is the reported biochemical changes in the Huntington's chorea, right? What is the reported biochemical changes in the Huntington's chorea? The reported biochemical changes suggest a relative underactivity of the neurons containing GABA and as well as the acetylcholine, right? So you have two things which will be happening here. There will be underactivity of the neurons, right? Underactivity of the neurons containing gamma aminobutyric acid and as well as the acetylcholine, right? Underactivity of the neurons containing gamma aminobutyric acid and as well as the acetylcholine. And there is overactivity of, right, there is overactivity of dopaminergic neurons, right, overactivity of the dopaminergic neurons. So these are the reported biochemical changes that you will have in patients with the Huntington's chorea, and accordingly you have to give the particular drugs. See, there is overactivity of dopaminergic neurons releasing the excessive dopamine. That is the reason why we are giving dopamine depleter, that is tetrabenazine. Okay, so if the question is asked what is the widely used drug to treat the dyskinesia in patients with the Huntington's chorea, that will be your tetrabenazine. Okay, because it is the tetrabenazine which will interfere with the dopaminergic neurons. Okay, so tetrabenazine, right? So this is the medication that interferes with the vesicular storage of the biogenic amines, right? So it interferes with the vesicular storage of vesicular storage of biogenic amines, right? And that is widely used to treat the dyskinesia in patients with the Huntington's chorea, right? Next, now at the same time you need to know what is the dosage and as well as route of administration of this tetrabenazine. Route of administration of this tetrabenazine is the oral route of administration, and if you see the starting dose of this particular tetrabenazine, it is 12.5 milligrams twice daily, right? 12.5 milligrams twice daily, or you have to give thrice daily orally. And from 12.5 milligrams you have to increase every 5 days, right? You should give orally 12.5 milligrams twice daily or thrice daily, increasing by 12.5 milligrams every 5 days depending upon the response, right? And how much will be the usual maintenance dose? Maximum you can go up to 25 milligrams thrice daily. So that is a maximum dose that you can increase up to in order to have a good response. That is about the route of administration and as well as the dosage of the tetrabenazine. And at the same time you need to know what are the adverse effects of this particular tetrabenazine. See, tetrabenazine, it is causing the dopamine depletion, right? So the side effects include the depression. There can be postural hypotension, that is when the individual changes the posture, that is from supine position to the standing or sitting posture, there will be fall in the systolic blood pressure by 20 millimeters of mercury, that is called postural hypotension. And these individuals also have drowsiness. Right, these individuals will also have drowsiness and Parkinsonian features. Okay, and so these are the adverse effects of tetrabenazine. And tetrabenazine should not be given within 14 days of taking monoamino oxidase inhibitors. Right, within 14 days of taking monoamino oxidase inhibitors, tetrabenazine should not be given. And at the same time, this tetrabenazine is not indicated for treatment of levodopa-induced dyskinesia. Okay, this is another important point. Right, not indicated in levodopa-induced dyskinesia. Right, not indicated in levodopa-induced dyskinesia. So please remember, this is a very, very important point. Okay, next, then followed by that, what is the alternative drug in case of the Huntington's chorea apart from your tetrabenazine? Okay, but before discussing this alternative drug, okay, alternative drug will be reserpine. I'll come back to this particular reserpine again. Right, I'll come back to this reserpine once again, but we have a drug called deutetrabenazine. Now what is this deutetrabenazine? Deutetrabenazine is also effective in reducing chorea in Huntington's disease, and it will have few side effects than tetrabenazine, but direct comparisons are lacking. Okay, so even this can be given to reduce the chorea in case of the Huntington's disease, and it has few side effects. Right, it has few side effects than compared to that of tetrabenazine. Okay, and what will be the starting dose of this particular deutetrabenazine? The starting dose is 6 milligrams, right, 6 milligrams once daily orally, right, once daily orally. So that will be the starting dose of the due tetrabenazine, and this is increased to 6 milligrams twice daily. Right, depending upon the response, this can be increased to 6 milligrams twice daily after 1 week. So you have to wait for 1 week. Right, after 1 week, you can increase this particular dosage to 6 milligrams twice daily. Okay, and maximum, how much you can give? Maximum dose that you can give is 24 milligrams twice daily. Right, the maximum dose that you can give is 24 milligrams twice daily. That will be the dosage of the due tetrabenazine. Right, next, then followed by that, let me discuss about this particular reserpine. So reserpine, it is similar in depleting central monoamines, but it has more peripheral effects. Right, it has more peripheral effects. Okay, and the side effect profile of this reserpine is also very bad. That is the reason why this reserpine is not very commonly used in patients with the Huntington's disease. Okay, and if at all it is utilized, the dose is built up gradually to between 2 to 5 milligrams orally daily. Okay, so the dose is 2 to 5 milligrams once daily. Right, depending upon the response, you need to give this particular reserpine 2 to 5 milligrams once daily. But please remember, the side effect profile of this particular reserpine is very bad compared to that of tetrabenazine. So that is the reason why we don't use this reserpine very commonly. Right, next, so in order to reduce this particular dyskinesia, what are the other alternative drugs? One, we have discussed tetrabenazine and as well as due tetrabenazine. Right, the alternative drugs to control the dyskinesia will be medications blocking the dopamine receptors. So what are those medications? Blocking right, what are those medications blocking the dopamine receptors? These medications include phenothiazines, right, phenothiazines or haloperidol. Right, phenothiazines or haloperidol. These drugs may control the dyskinesia and any behavioral disturbances. Right, these drugs will control the dyskinesia and any behavioral disturbances. Okay, so these are the alternative drugs to control the dyskinesia apart from your tetrabenazine and as well as the due tetrabenazine. And if you take this haloperidol, what is the dosage of the haloperidol? Haloperidol treatment is usually begin with a dosage of 1 milligrams once or twice daily. Right, you have to give 1 milligram orally. Right, you have to give this once daily or twice daily. Right, from 1 milligram you can increase this to every 3 or 4 days. Depending upon the response, you can increase the dosage of this particular haloperidol. But as of now, initially you have to start 1 milligram once daily. Right, next. Now we have a very important atypical antipsychotic agent used for dyskinesia in case of the Huntington's disease, right? And that particular atypical antipsychotic agent is the quetiapine. Right, this will be quetiapine. So what will be the dosage of this quetiapine? You have to give 25 milligrams and you have to give this orally. And the maximum dose of this quetiapine that you can give is 100 milligrams twice daily. Right, 100 milligrams twice daily. So this will be the atypical antipsychotic agent used for the treatment of the dyskinesia. And we have another important drug called amantadine used in the treatment of the Huntington's chorea. What is the purpose of using this amantadine? It is helpful for the same chorea, that is involuntary movements. But what will be the dosage of this amantadine? The dosage is 200 milligrams to 400 milligrams daily. Right, 200 milligrams to 400 milligrams daily, and it has to be given orally. Right, it has to be given orally. And I said you that in patients with the Huntington's disease or Huntington's chorea, you also have the behavioral disturbances. Then how do you treat these behavioral disturbances? The behavioral disturbances, they may respond to clozapine. Right, they may respond to clozapine. Okay, so that is about the treatment in case of the Huntington's chorea. And let me tell you, in Huntington's chorea, there is a very important role of the deep brain stimulation as well. Now, what is the role of deep brain stimulation? Deep brain stimulation has been used successfully to treat chorea in a small number of patients. Right, in those individuals who are refractory to the medical management, in them you need to do the deep brain stimulation. Right, and at the same time, how do you approach offspring of patients with the Huntington's chorea? Right, offspring should be offered the genetic counseling. Right, the offspring should be offered the genetic counseling. And this particular, not only genetic counseling, the genetic testing. Genetic testing permits pre-symptomatic detection and definitive diagnosis of the disease. Okay, genetic testing what is the use of this is, it will permit the pre-symptomatic detection and definitive diagnosis of the disease. Right, definitive diagnosis of the disease. So that is the purpose of the genetic testing. Right, now let me just summarize the entire treatment of the Huntington's chorea. So what exactly is, see, there is no specific treatment for your Huntington's chorea. It is only just symptomatic treatment. Right, and even the progression also cannot be halted. The drug of choice will be tetrabenazine, which is a dopamine depleter. Right, and this particular tetrabenazine, it is widely used to treat the dyskinesia, that is abnormal movements in case of the Huntington's chorea. The dosage is, you need to start with 12.5 milligrams twice or thrice, two times or three times daily orally. Maximum you can give 25 milligrams 3 times. The adverse effect of tetrabenazine include depression, postural hypotension, drowsiness. And this tetrabenazine should not be given within 14 days of taking monoamino oxidase inhibitors. And it is not indicated for the treatment of levodopa-induced dyskinesia. And the alternative drug in case of the Huntington's chorea is the reserpine. But because of its worse side effect profile, this is not being used very commonly. And we have another drug called deutetrabenazine. See, deutetrabenazine, it has the few side effects. The starting dose is 6 milligrams once daily orally, and you can increase to 6 milligrams twice daily. Right? And maximum dose that you can give is 24 milligrams twice daily. So that is about the dosage of the deutetrabenazine. And what are the alternative drugs to control the dyskinesia? That is the drugs which will block the dopamine receptors, such as phenothiazines or haloperidol. Even these phenothiazines or haloperidol may control the dyskinesia, and any behavioral disturbances can be controlled. And haloperidol, you need to start 1 milligram once or twice daily, and it has to be given orally. Right, and the atypical antipsychotic agent used for dyskinesia will be the quetiapine. Right, and what is the role of amantadine? Amantadine is also helpful in reducing the chorea, and you have to give 200 milligrams to 400 milligrams daily, and it has to be given orally. And the behavioral disturbances can be treated by your clozapine. Deep brain stimulation is mainly used to treat the chorea in a small number of patients. And this offsprings, you need to do genetic counseling. or genetic testing will permit the pre-symptomatic detection and definitive diagnosis of the disease. And finally, what are the essentials of the diagnosis? So the chorea, whatever is there in patients with the Huntington's, it is gradual in onset and there will be progression of chorea and dementia or behavioral changes. Family history is also very important. It is autosomal dominant type of inheritance. And the gene which is responsible, it is present on the chromosome 4. Now, you see the question here, which of the following cerebral blood flow patterns is likely in a patient with Huntington's disease? Hyperemia to basal ganglia with reduced flow to other areas in the brain, bilateral reduction in blood flow to the caudate nucleus, bilateral reduction in blood flow starting from occipital cortex and spreading anteriorly, decreased blood flow to the temporal lobes. Okay, so the structure which is being affected in case of the Huntington's disease will be the caudate nucleus. So there will be bilateral reduction in blood flow to the caudate nucleus, right? So the disease predominantly strikes the striatum, right? And even if you take the SPECT, there is single photon emission computed tomography using technetium 99M, that will show significant reduction in the SPECT tracer uptake in caudate nucleus and as well as the putamen. And gradually, if we see, there will be progressive atrophy of the caudate nuclei, right? And this particular caudate nuclei, they form the lateral margin of the lateral ventricles. And this can be visualized on the MRI in the form of what is called boxcar ventricles, right? So these are some of the very important points related to the Huntington's chorea, where the individual's presentation will be in the form of fast semi-purposive movements in the upper limbs. With this, let me wind up this session. Thank you very much.